Chapter 43, Nursing Care of the Child with an Alteration in Urinary Elimination and Genitourinary Disorder. Our learning objectives for the week are to talk about some differences of the anatomy and physiology of children versus adults. We're going to talk about some of the lab and diagnostic testing used. Talk about some of the disorders that we see in kids. We're going to identify some nursing assessments and psychosocial impact of this problem. So when we talk about structural differences, we're talking a little bit about, what we see in kids. So congenital disorders, we see a lot of those in infants in the GU system. We also see illnesses like UTIs. The kidney is larger in relation to the abdomen, so protection of the kidney by the ribs is not as evident in children. The urethra is shorter in all ages of females compared to males, and so they're at risk for UTIs. The GFR is slower, so they're at risk for dehydration. They can't concentrate their urine, and so it places them at that increased risk of dehydration when they have any type of fluid loss. They have a small bladder capacity, and then the reproductive organs are immature. This was just an interesting slide that I found, that low set ears can be an indication of some urinary tract abnormalities or anomalies. Some of the tests that we're going to use is we talk a lot about urinary cultures and urinary cultures and urinalysis. Sorry. We talk about clean catch. We did some catheterization of kids in the lab. Suprapubic taps sometimes are used if they can't obtain a sterile urine specimen. What we're looking for for positive urinalysis to dictate that there's an infection is we're looking maybe for some blood, not always. It depends on if it's a traumatic catheterization or not. Looking for nitrites because bacteria turns the nitrites into nitrites. We're looking for leukocyte esterase, white blood cells, and maybe some bacteria. And then what they'll do is a urinalysis, check a basic urinalysis, and then they'll culture that out so that if a urinalysis is indicated or found, then they will culture it to find out what the organism is, and then the physician will get a list of sensitivity. So you want to treat the urinary tract infection with the correct antibiotic. Often, if they suspect a urinary tract infection from the urinalysis, they may go ahead and treat with a broad spectrum antibiotic. But then once they find out what organism it is and what it's sensitive to, they may change the antibiotic at that point. Again, we talked a little about urinary tract infections. So children have a small urine output, and then obtaining that clean catch or sterile urine specimen, which we practice in the lab, is what is necessary. This is just a little picture of a suprapubic tap, and that's sometimes how they will obtain a urine specimen. A physician will, if we're unable to do a catheter on a kid, or if it's, emergent in NICU or things like that. You may see that. Some of the structural disorders we see is in boys hypospadias and epispadias. So hypospadias is an opening on the ventral surface rather than at the end, and epispadias is the opening on the dorsal surface. Either way, it needs to be repaired. If it's left uncorrected, then they may not be able to aim a urine stream and from the standing position. Typically, it's repaired. Years and years ago, it wasn't. I remember my very first catheterization on a male, and he had epispadias, and it just had not been repaired. The thing with repairing this, you want to do it before they are potty trained, and you also want to hold off on circumcision for in either of these disorders because they may need some of that skin to repair the area. UTIs are caused usually by E. coli. When we talk about UTIs, we talk a little bit about how it's bacteria is going into the bladder. Sexually active females are more at risk for development of UTIs because the bacteria may be forced into the bladder from intercourse. The adolescent male is they say is a little bit protected from UTIs because of the properties of the prostate secretions. Children aren't going to present the same way having a UTI that we would as an adult. So an infant is going to have that irritability, inconsolability. They could have a fever, vomiting, failure to thrive. They could even be jaundiced. Children sometimes complain about stomach pain. They also could have some dysuria. They could experience fever and vomiting. Usually caused by E. coli. I talked a little bit about that, although it can be caused by other things like Klebsiella, Staph, Pseudomonas, or Haemophilus. But urine that remains in the bladder is obviously going to allow bacteria to grow. And then decreased fluid intake leads to UTIs. Untreated bladder infections can it can allow reflux and then can lead to a pyelonephritis, which is much more serious. We treat UTIs with oral or IV antibiotics, depending on the how sick the child is. And one of the education pieces of this is to make sure that they finish the prescription. When we talk about enuresis, so enuresis is incontinence of urine past the age of toilet training. Your book breaks it down into primary, which means that they've never been able to achieve voluntary bladder control. Secondary is they have had full bladder control, but something has happened that they start wetting the bed or wetting themselves. Diurnal is loss of control in the daytime, and of course nocturnal is bedtime wetting. Sometimes there's some other associated diseases with enuresis. Could be diabetes, sickle cell, could be an obstruction, could be caused by constipation or emotional distress, like maybe parental divorcing or fighting or new baby in the house, things like that can cause it. And then nocturnal enuresis is sometimes caused by drinking too much fluid in the evening. Those of you who had kids know that they always want something to drink before they go to bed. And then sleep apnea can also cause it, and then also sexual abuse. So a lot of the education is about voiding when you need to. Your book mentions some resources to help kids, empty their bladder when they should, decreasing nighttime voiding by decreasing fluid intake, things like that. Some acquired disorders that are going to affect their renal function is nephrotic syndrome. So that is a problem with the membrane permeability, and they lose protein, so they have proteinuria. It's not really common. It's usually congenital, is inherited from families of Finnish descent. Poor prognosis is something they live with the rest of their life. And usually the problem is that loss of protein. So I think I've seen 1 or 2 kids in my life with nephrotic syndrome. They are on sometimes long-term steroids, so they have the moon face, and usually have fluid electrolyte issues. Acute glomerulonephritis, so it's usually post-streptococcal, so it is infection and causes inflammation, and then usually it can follow upper respiratory, like strep throat or skin infection, and there's no really medical treatment for it, but they maintain the fluid volume, one of the classic signs or the cardinal signs of acute post-streptococcal glomerulonephritis is tea-colored urine. So it's gross hematuria, but it's not going to look bright red. It's going to be tea-colored or Coca-Cola colored. Their creatinine and BUN would probably be elevated too. Sometimes they would give antihypertensives if needed, fluid and sodium restrictions. Kids can live a normal life. They just may have some problems for a while, but usually it's not a lifetime issue. We're going to talk a little bit about, I don't go into renal failure and end stage because we see that in adults or dialysis. We talk a little bit about some reproductive organ disorders. In the infant girls, we might see partial or complete adhesions of the labia minora. There's a good picture in your book on page 1658 of the labial adhesions. Sometimes the labia is fused so much that we can't get a urine specimen. They're able to pee because some can just kind of slip out, but that would be when the doctor would do a suprapubic tap. Sometimes we see this in the premature infants. And then we would usually they'll administer steroid cream or jelly to help that soften and open up. We see vulvovaginitis, which is inflammation of the vulva and the vagina. It's usually bacterial or yeast. So this is why we tell little girls don't, soak in bubble baths. Certain soaps, perfumes can be found to be irritating. Poor hygiene, wearing tight clothing, scratching, itching, things like that. So really just treat the symptoms of that. We don't go into pelvic inflammatory disease because we see that in the adult. We will talk a little bit about menstrual disorders. Menstruation usually begins about 2 years after their secondary sex organs start forming, so breast development, and around 12 to 13 years. It really depends. And sometimes we see disorders with menstruation. We can see primary amenorrhea, which is they don't start their period within 2 years of reaching that. They talk about the Tanner stage, but reaching that development stage. You can have secondary where they've had their period and then stop for a while. And the most common cause of that would be pregnancy. Middle smirch is that abdominal pain that they have, cramping pain about midway through the cycle. Dysmenorrhea is pain with menstruation. So people who have endometriosis or fibroids have this. Menorrhagia is excessive menstrual bleeding. So sometimes this is the time when they have to go in and do an ablation or things like that. And then menorrhagia is bleeding between periods. So sometimes it's they're not using their contraceptives correctly, or they have an IUD that's causing them not to bleed, or it could be miscarriage or an ectopic pregnancy. It's the age of menstruation has really dropped in the last decade. I don't know. Some people say it's because of all of the things, how our foods are made now and things like that. Kids who are anorexic will be delayed in starting their period, and sometimes obese girls will start them earlier. For the boys, we talk a little bit about phimosis and paraphimosis. So phimosis is the foreskin can't be retracted at all. We talked a little bit in lab about how parents aren't pulling the foreskin down to clean it. And so if they don't pull it down at least to clean it, then they won't be able to be retracted. Over time, it should be able to be retracted. And then paraphimosis is really that more serious disorder when the skin is retracted and then not able to be pulled up again. And then they can get what's like a little tourniquet of skin at the bottom and cause damage to the penis. Circumcision, you know, we talk a lot about circumcision, and your book talks about some benefits of it. Decreased incidence of UTI, sexual transmitted diseases, AIDS, cancer. In females, decreased incidence of cervical cancer. There's not a lot of evidence to really show that. This book was written probably in 2015-16. Circumcision is truly a family decision, personal decision based on their religion or their social, cultural customs, and we should just support it one way or the other. Cryptorchidism is undescended testicles. The concern with cryptorchidism is that when the testicles do not descend into the scrotal sac, either one or both of them, there is more of a risk for cancer, testicular cancer, and also decreased sperm production if they're not repaired. Usually around the 7th month of gestation is that they make their descent, and for some reason some kids don't. So if a child has cryptorchidism and it's repaired, they still are at risk for testicular cancer. So checking for cancer is important for them the rest of their lives. They will do surgery to repair that, and orchiopexy, and that releases the spermatic cord and allows the testicles to be pulled down. So risk factors are prematurity, the firstborn child, cesarean birth, low birth weight, and if they have hypospadias. So you'll notice when you get to OB, when they're doing the newborn check, they're checking the testicles to make sure both have descended. Two conditions that we see in boys is testicular torsion and epididymitis. Torsion is obvious that it's twisting of the testicle. It's immediate emergent surgery after an ultrasound to confirm it, because if you don't repair that, then they could lose all blood supply to the testicle. Testicular torsion is severe pain, swelling. It can look black and blue. And so the only way to fix that, like I said, is surgery, and it's a medical emergency. Epididymitis is more an infection, so inflammation caused by bacteria. Most common kind of sign of pain in the scrotum in children. Rarely occurs before puberty, but it also can result in a bladder infection after that. So testicular torsion is immediate pain, immediate surgery. Epididymitis is more of a slower pain because it's an infection, and it can be treated with antibiotics. You might see epididymitis also with chlamydia infections, gonorrhea infections, any of your STIs. Here's a little picture to compare phimosis and paraphimosis, and then this is a picture of cryptorchidism with the undescended testicle. So this just talks a little bit about complications and benefits of surgery for circumcision. And these are some of the tools that they use to do the circumcision. It's pretty brutal surgery. Had I known what I know now, I may not have had my son circumcised. But again, it's a decision that the family makes, and we will support that. One of the biggest things with the GU system is maintaining that fluid and electrolyte balance. We talked a little bit about dehydration in the last chapter, but assessing for intake and output, diuretics if needed, and then monitoring for any type of electrolyte imbalances. And then this goes into like renal failure, renal surgery, things like that. Psychosocial, so our data that we're assessing for past, in the past is polyhydramnios, which is an excessive amount of amniotic fluid, oleohydramnios, so not enough fluid, diabetes, hypertension, and then any kind of drugs or alcohol. Neonatal, you'll notice when you are in OB that they check the placenta, they check to make sure that they have their arteries and veins. If they have a mass, sometimes they could have a chromosomal abnormality or other congenital malfunctions. And then any family history of any type of diseases with the urinary tract, they would be more at risk. Okay.